Happy April Fool's Day to everybody. I don't have any good jokes, unfortunately. All business today. So we'll start with Parkinson's disease or Parkinsonism, however you want to define it. It happens to have a similar amount of symptoms. Depending on the source, though, is usually how we treat it differently. So, for example, Parkinson's disease is usually the disease we associate with movement disorders that we manage specifically. Parkinsonism is more associated as a drug side effect. So antipsychotics are a good example of medications that can cause Parkinson's disease-like symptoms, and that's called Parkinsonism. Anyway, just use it as an umbrella term for the different movement disorders we're going to talk about. But really, we're just going to focus on Parkinson's disease, or PD, as our primary disease state to talk about today, and focus on the drugs used to treat it, because it really is what would apply to any type of movement disorder. So anyway, what you're going to see with Parkinson's disease is resting tremor, rigidity, bradykinesia, and postural instability. It doesn't really have a known cause, but we do know that there are different neurochemical abnormalities and possibly some genetic and environmental factors as well, possibly things like drugs of abuse, environmental exposures I've listed there. A lot of weird correlations like high body weight and milk consumption. I mean, I don't know. I kind of don't think that's really something that, again, correlation, not necessarily a causation, or maybe a combination of several things, right? Age over 60, double the risk. So this is more of a significant prevalence in our geriatric population. So for example, over 60, the prevalence is about 2 to 4% versus 1 to 2% under 60. And then here's some European data. Over 65%, they show 1.6% prevalence, and over 85%, 3.5%. So significantly higher the more you age. So it is associated with aging. I wouldn't necessarily consider it one of those things that just happens to you as you get older. It's still pretty low. I mean, 3.5%, that's a decent chunk of the population, but it's not, like everyone's going to get there eventually, right? So it's still something you aren't going to see in the vast majority of people, but it is a relatively common neurological condition. It's also more common in men than women. As far as the pathophysiology, very briefly, the idea is that there's some kind of dopamine producing cells in the substantia nigra, which is a part of the brain, as you can see listed in this diagram here. And you get diminished substantia nigra during Parkinson's disease, which basically means you can't produce as much dopamine. Dopamine has a lot of different functions. I think we think of dopamine as a reward system hormone, or a pleasure-related hormone. We get a release of dopamine when we eat a good meal, or people abuse drugs because they get a dopamine release. We'll talk about that during drugs of abuse. But in Parkinson's disease patients, there are areas that are making dopamine for the purposes of movement. So dopamine also affects the way that the body moves. And in different areas of the body, or in different areas of the brain, dopamine does different things. So in some parts of the brain, it might affect your pleasure response. In other parts, it affects movement. And that's the case in the substantia nigra, that you have a lack of dopamine, so you can't regulate your body's movement as well as you could if you had a functioning dopamine producing area in the brain. Just an infographic about Parkinson's disease. Michael J. Fox is sort of the, more or less, well, I guess this is a poster, so I'm not trying to be funny here, but the poster child for Parkinson's disease. He is a very famous person who has the disease and has a very public relationship with it. He's done a lot of discussions on it and things like that. There's a video here that I'm not going to show you, but I would encourage you to watch it. I think it's interesting, and it's got some humor to it, but I think it'll show you a little bit about what the patients might experience, or what a normal patient would experience. He talks about how he skates, and that helps with the symptoms. And when he's out skating, he doesn't really feel like he has the movement disorders. It's more like when you're at rest. And that's pretty common too. People, if you think about the way it's linked to dopamine production, if you're doing something that's generating a pleasurable response, you might be generating enough dopamine in different parts of the brain to cross over so that you're getting a good supplementation effect. But if you're just resting, or just doing nothing, or working, or whatever it might be, that's not really generating a whole lot of a reward system in your body, you might not experience that. So anyway, I encourage you to watch it. It's really short. New York Times published a number of things called patient voices. It's kind of old technology, and it's from like 2008, so they're just recordings of people and descriptions of them. But if you want an experience about some people's or want to experience some people's relationships with their diseases, not only do they have some good ones for Parkinson's, but they have a lot of different ones from everything from diabetes. They also have some really great ones for mental health conditions too. I think for me, I always like to listen to people's experiences with the disease. I think it helps put a perspective on it that you don't otherwise get if you don't actually have the disease. Okay, protective factors, or anything you can do to protect yourself from Parkinson's disease. This is kind of interesting. Smoking, actually, I don't think this is a good reason to smoke. I'm pretty sure all the risks outweigh the benefits. However, I will say it here because I think it's interesting. Statistically, nicotine has a possible neuroprotective effect. And there's thought that people who don't smoke might have a higher risk because they don't necessarily engage in reward-seeking behaviors as frequently, whereas somebody who is a smoker is doing that consistent reward process where they're constantly smoking and engaging their reward system. I don't know. I think it's interesting overall just to talk about it because it's how the brain is interacting with itself and can you actually delay a certain type of disease? So anyway, yeah, smoking might have a positive benefit for delaying or preventing Parkinson's disease. However, again, not necessarily something you'd recommend. Now, maybe if somebody had a really high family history or something like that, and they're like, I want to start vaping because I heard it's better, maybe that would be healthy. Again, I wouldn't recommend it. We'll talk about that in the next module. But anyway, I think it's an interesting discussion. Parkinson's disease patients actually have a pretty low prevalence of cancer compared to the general population, which is again kind of interesting. So why all this? Does any of this mean anything? No, absolutely not. Not in my book, and not in I think the major medical community's book. But it's still it's an interesting conversation to have. Caffeine and caffeine intake have some possible protective factors. Physical activity. Patients actually who are active and have a sudden drop in their activity, that might be a preclinical sign of Parkinson's disease, and the patient might not actually realize that they are, in fact, experiencing Parkinson's symptoms early because they just think of it as, well, they're getting older, maybe they aren't as coordinated as they used to be, they aren't enjoying activity as much, or they're having difficulty doing whatever they used to do. That could just be because their body's not coordinated well with respect to having movement disorder issues. And it's very early, but they don't notice the overt onset of Parkinson's disease like you might think about. So somebody in the general population might think of Parkinson's disease as severe tremors and heavy movement disturbances and things like that, whereas preclinically it might be much more subtle than that, but it still might also affect the way that you can move. And so that actually might decrease physical activity. So that's why it's important to gauge physical activity in your patients, especially your older patients, and talk about if there's changes or not to that. Because again, it's more prevalent in that population, and you'll see the progression happen earlier. If you can catch it, you might be able to do some treatments earlier that might help in the long run. Maybe, maybe not. We'll talk about that in a little bit here. Ibuprofen, NSAIDs have been studied and maybe have some protective factors, but the evidence is really weak. So I'll just put that in there again. Interesting conversation. All right, so dopamine levels in a normal and a Parkinson's affected neuron. Here's a cartoon that probably does exactly what I've just been describing. Lots of dopamine here, not dopamine here. So basically you're having some sort of a I don't know if neurodegenerative is the right terminology for Parkinson's disease, but some sort of neurologic damage in a certain part of the brain that's again going to affect the way that the body can move with dopamine. So we have broad options, both pharmacologically and surgically. There's pharmacologic options that are, and of course I'm going to talk about pharmacologic, not the surgical. The surgical side of things is a little bit more interesting. I think there's some cool stuff out there. This is one of the diseases, and I think Michael J. Fox is active about this, but stem cell research is one of the ones where they always talk about, well, if we could grow maybe a new part of the brain and do stuff, I don't know, replace some of the cells or something like that, some advanced neuroscience there. Again, surgical interventions, treatments that don't really exist yet, future stuff. But pharmacologically, we don't have the best treatment options. And in fact, we're kind of lacking in some of them, which is why this is sort of a short lecture. But anyway, neuroprotection is very pie in the sky at this point. Most neuroprotective benefits from a pharmacologic perspective are theoretical or investigational. There's not really any conclusive benefit that anything we do pharmacologically will have neuroprotective benefits. We can help with symptoms, which is what the second bullet point is here, which is what most of our current therapies do. But everything else we've tried really doesn't necessarily have that benefit. However, there's some theories behind this that some of the drugs we use to treat, like dopamine agonists and MAO-B inhibitors, which I'll talk about in a second here, are possibly neuroprotective. Supplements such as coenzyme Q10 and vitamin E have been studied. Probably not helpful. I mean, that's pretty much the standard where you're going to read any study with supplements, is that there's very few supplements that are guaranteed to be protective against some disease out there. Doesn't mean we can't study them, but there's not a lot of money in it, so it doesn't happen very often. And when it does, you usually don't really see a huge benefit. So just broad stroke there. Dopamine therapy is generally speaking, the most common treatment for most Parkinson's patients. Now, there is some caveats there, and we'll talk about that here in a little bit, but I want to talk about the drugs first. So levodopa, or L-dopa, is synthesized from tyrosine, which is a catecholamine precursor. It crosses the blood-brain barrier and then gets metabolized into dopamine. So basically, think about it as a dopamine precursor that our body synthesizes endogenously, but you can give it in drug form too. The problem is you have to get it across the blood-brain barrier. So dopamine itself doesn't cross it. So if you gave somebody an infusion of dopamine or a tablet of dopamine, it wouldn't do anything. They would just get some probably blood pressure related effects from it because it's a pressor. But what we want to do is get that levodopa we got to get that dopamine into the central nervous system. So from a pharmacologic perspective, it's a little bit challenging. The other product is called carbidopa, which doesn't cross the blood-brain barrier, but it inhibits peripheral metabolism of levodopa. So what happens is that levodopa, if you gave it as a standalone supplement, will get metabolized very rapidly into dopamine and won't get into the blood-brain barrier as efficiently. Now, if you give it with carbidopa, it prevents some of the peripheral metabolism, allowing more of it to get into the central nervous system. Therefore, you reduce the peripheral dopamine side effects and you get your drug to the site of action. Now, even with all this, the half-life of levodopa is really short. It's like 1 to 2 hours. So you don't get a lot of activity after taking this drug. That's one of the biggest barriers to this type of therapy. The product that came out on the market first was Sinemet, which is the brand name. It's been generic for quite a while. And Sinemet is a combination of carbidopa and levodopa. You can see it here and how it's done. Doses vary really tremendously, I would say. So sometimes you might have a patient with early Parkinson's and they might be on it 3 times a day is pretty usual. Again, it's very short acting. So you think about it, 1 to 2 hour half-life, you take it orally, it takes, an hour to absorb, or maybe 2 hours to reach its maximum concentration. Then you've got maybe 3-4 hours of decent area under the curve before it's out of the system and not really effective anymore. So 3 times a day is about the minimum you're going to see people taking carbidopa, levodopa. What they do is they'll start you on a lower dose at a less frequent interval, and then they'll increase you. So I've seen people on 5 times a day, 6 times a day. I've seen people taking the extended release 5 times a day, 6 times a day. So it really just depends. But usually, just like with any therapy, really, you start low and gradually work your way up. Immediate and extended release tablets. There's also this Parcopa product, which is an orally dissolving tablet. There's a newer brand name called Rytary, which is another controlled release, but Sinemet CR is the original. So Sinemet brand or generic is just the immediate release. Sinemet CR is the extended release. All of them are generic now, with the exception of this Parcopa and Rytary. I'm not sure I don't think, from what I've read about the Rytary extended release, it's not as it doesn't really have any substantial benefits over the regular extended release from what I can tell. But with some of these patients, they've tried a lot of different stuff and they're on really high doses. So trying maybe a different release mechanism might be advantageous. Just depends on the person. All right, side effects. This should be a comma here. Sorry, not nausea, somnolence. I'm not sure what that means. Sorry. Grammar police. So nausea is by far the biggest issue here. So if you gave somebody just levodopa, what happens is you can get this effect where it hits the chemoreceptor trigger zone, which causes a vomiting response. Now that happens if the drug stays out of the blood-brain barrier. So if you give somebody like straight dopamine, they're going to probably feel sick because it's going to trigger receptors in the chemoreceptor zone. If you can get it all into the central nervous system, it's perfect, but not all the drug goes into the central nervous system. So some of it stays outside, and that's where people get nauseous. It can cause some somnolence too. People might feel sleepy. Dizziness and headaches are common. And this is a big one too, the second bullet point. So with older patients or prolonged high-dose therapy, what you start to see is psychosis. And we'll talk about schizophrenia and antipsychotics and how they work, but they basically block dopamine. And one of the theories behind why schizophrenic patients experience voices and hallucinations and things like that is because they have an overexpression of dopamine in some areas of the brain. So thinking back to our mechanism of action, what you have is a deficiency of dopamine in one area of the brain. So we want to get dopamine ideally right to that spot. However, it goes into different parts of the brain because really what you're giving the brain is just dopamine. So the brain's going to use dopamine wherever it uses dopamine because it's all of a sudden in systemic circulation because you gave it in a drug form. So some of that dopamine is going to go to the areas of the brain that have more behavioral effects and thought effects. And that can cause disorders that very closely mimic psychotic patients and schizophrenia. So in this case, it's a tricky treatment to manage, and we'll talk about, or a tricky side effect to manage, and we'll talk about that specifically by itself. Abrupt cessation can be pretty problematic. NMS is neuroleptic malignant syndrome. It's sort of like a really intense movement disorder thing that you see with antipsychotic therapy that has to do with blockade of dopamine. Basically, it's a cessation of dopamine therapy, and then really kind of like a movement paralytic type crisis, which can be really problematic. You can affect people's respirations. You can put people in an ICU. I've seen a couple people get NMS over my career working in psychiatry, and they do end up in the ICU. They can be really tricky cases and fairly high mortality rate with stuff like this. So cessation, stopping it, we really want to make sure we gradually, if you decide to get to the point with Sinemet where it just isn't working anymore, you just want to taper it off gradually. Don't ever stop it right away. Dopamine free radicals, I'm not going to talk about that. I think that's pretty theoretical. I don't have any evidence to support that. And then the release mechanisms, I would just say start with your immediate release products, and then move to the ER. There isn't any benefit to starting extended release right away. Extended release isn't that great, just to put it out there. So you might get like an extra hour or two at most, but it's not like you're going from 3 times a day to once a day with extended release. It's not that much different than the regular product. So that's the problem with ER. Stalevo is a product that basically takes the Sinemet building block, carbidopa-levodopa, plus it adds entacapone, which is a reversible catechol methyltransferase inhibitor. So what this does is it alters levodopa pharmacokinetics, which sustains levodopa serum levels, allows increased concentration and better, more sustained absorption across the blood-brain barrier. Why is this used often? Yes and no. There's another product kind of like entacapone called tocopone, which is a standalone product. So you could buy this by itself and combine it with carbidopa-levodopa. But the combination is available too. It is generic now, so you can get it without a branded product, so it's relatively affordable. You might end up seeing more severe levodopa effects, so you might have actually a higher concentration and more GI-related side effects with this. But you also might be able to get a few more hours out of your therapy too. So I don't know what's better. I think, again, you start with just the basic carbidopa-levodopa. I'd probably go carbidopa-levodopa, immediate release, try extended release. If you aren't getting the effect you want, maybe try this product after that, or try adding this onto it. Dopamine agonists. So switching gears a little bit, a dopamine agonist directly stimulates dopamine receptors in the central nervous system. So you initially have this medication designed as an adjunct therapy. However, some people will argue that they do not promote further neuronal degeneration, which people will argue that the carbidopa-levodopa will actually promote degeneration over time because you're kind of overtaxing the system and you're allowing whatever dopamine activity you have remaining to atrophy because your body doesn't need it anymore. So the idea here is that your body can use whatever dopamine generating process it still has intact to keep that running. And you can augment that by directly stimulating the receptors and possibly even upregulating receptors and things like that. Some people will argue use it first instead of Sinemet or postpone Sinemet necessity until disease is more severe. But the bottom line is that Sinemet is the most potent drug we have for Parkinson's disease. So it really depends on your patient's symptoms and what they're experiencing before you'd pick which one to start with. And again, I'll spell that out a little bit more in a couple slides. So keep that thought in mind for a second. Fewer motor fluctuations with dopamine agonists. They're more steady state and they last a lot longer. A lot of people say that they're better options for patients less than 60. Not always the case. You can combine them with Sinemet. However, if you've given somebody Sinemet and they don't respond, they probably won't respond to a dopamine agonist either, but they might get synergy if they are getting a response from Sinemet. The products on the market, bromocriptine is a really old one, not really used anymore. The other two are pramipexole and ropinirole. You might know these. They're also used for restless leg syndrome, but we'll talk about that during the miscellaneous neurotopics quickly. They're dosed 3 times a day or multiple times a day, but they come in extended release too. They've been around for a little bit. They're generic, and I think they're, for the most part, reasonably affordable. There's also a transdermal patch that's once daily. So if you have somebody like an elderly patient who might have some dementia going on, this might be a good option for some people to take as opposed to taking oral pills. It also might give a more sustained release process, which could help people's symptoms be managed on a more steady state as well. Adverse effects, similar to levodopa, you will see nausea and vomiting, sedation, orthostatic hypotension, and then ultimately confusions and hallucinations. Because again, while these drugs are targeting dopamine receptors specifically and usually movement disorder areas of the brain, they can cross over into other areas too. They're overstimulating dopamine receptors in, again, areas that involve thoughts and behaviors. You can end up with some of those psychosis-like symptoms. Peripheral edema is seen. And then behavior. So this is kind of an interesting point. We talked about dopamine and the body's natural pleasure reward system and how it's the primary neurohormone there. And so some people might see compulsive use of these medications. Like, for example, a younger male patient might have issues with this and take more drug because they might get some sort of a reward system type effect off of it. I wouldn't call it like a buzz or a high or anything because I think it's a little bit different than that. But that could actually lead to more dyskinetic type effects, and they could end up with severe side effects from doing that because they're taking it compulsively or taking more than they're prescribed. It has been documented. It's not a super common thing, but it is documented in younger male patients mostly. You can precipitate mood disorders as well, such as mania or hypomania. If you have a patient who has a history of bipolar disorder, I would be very cautious with these drugs. Impulsive behavior such as hypersexuality, gambling, buying sprees, things you'd associate with a manic phase, those are all kind of fair game and have been seen on these medications. And on the flip side, for older adults, you can potentiate cognitive dysfunction as well. So you're probably thinking to yourself, okay, so you don't want to give these to younger people or older people. No, let's slow down a second. You can give them to them. You just want to be careful with the side effects. If you have a person who's got a history of bipolar or history of compulsive behavior or history of addiction, maybe try something else. And then older patients who already have maybe some early stages of memory loss or cognitive dysfunction, I would maybe be cautious. But people who don't have those backgrounds, I think they're pretty effective drugs for the most part. Titrate slowly. People don't tolerate them very well if you give them high doses because of this. So crank it up really carefully. And usually that can avoid a lot of these side effects ultimately. Interesting side effect, abrupt somnolence without premonition. So people just fall asleep randomly, kind of like I would think like narcolepsy, but not quite, associated with pramipexole. Withdrawal. People withdraw from these kind of nasty, similar to cocaine. They get anxiety, panic, sweating, depression. It's not life-threatening. You can't really treat it with anything other than just giving the dopamine agonist and then tapering them off. So just like with Sinemet, you'd want to taper these slowly if you're going to stop them on a patient. MAO-B inhibitors are, MAO is monoamine oxidase, and type B is the specific type of enzyme that inhibits this particular process. So what MAO inhibitors are an old class of antidepressants that basically inhibit the process of breaking down different types of neurotransmitters. So things like serotonin, norepinephrine, dopamine. In this case, the idea is that the specific subtype inhibits the enzyme that's going to break down dopamine in the central nervous system. So you get a higher amount of dopamine circulating in the central nervous system. Products like selegiline and rasagiline are the two drugs on the market right now. They're selective for the B-type MAO. One of the things about the side effect with monoamine oxidase is that you can end up with a really severe reaction if you consume foods with lots of tyramine in it. And the basic science behind it is, so tyramine has an effect that it's a precursor to all of our neurotransmitters. So if you ingest a lot of tyramine and you're inhibiting the enzyme that breaks down the neurotransmitters, your body can end up making a lot of norepinephrine, a lot of dopamine, a lot of serotonin. What that can cause is a hypertensive crisis. People can actually basically think about it as having circulating vasopressors around in your body, more so than your body can't break them down, right? So normally it makes them, breaks them down. Everything's in balance and it works great. In this case, you're messing with that in the sense that's going to cause your body to have an overexpression of some of these neurotransmitters and neurohormones. What happens is you get hypertensive emergency in some cases. So people like, or foods like aged cheeses, beer, aged meats have to have tons of tyramine in them. So people just need to be a little bit careful with it. For the standard antidepressants that are non-selective, the older drugs, it's a much bigger risk. For these medications, it's still something to consider, but not quite as high of a risk. Selegiline comes as a transdermal patch, and rasagiline is oral only. These are maybe thought to be neuroprotective because they are, again, working with the body's, working differently than just overloading the body with dopamine, although that's kind of what they're doing, but they aren't providing, the difference being here is that they're not providing a external source of dopamine, but they're working with the way that the body produces dopamine. So it's a little bit different if you think about it that way. Normally, we don't use these as monotherapy. There are some caveats to that, though. Side effects. Selegiline can cause confusion in the elderly, and any other antidepressants, you could possibly have an interaction that causes prevalence of too much neurotransmitter, such as serotonin or excess serotonin. So there is some caution there. Anticholinergics are probably the least used class, so I'm going to skip over them very briefly and just skip to the bottom. They cause, as you'd expect, anticholinergic effects. So dry mouth, urinary retention, constipation, and then also issues with the elderly, especially ones with the beginning signs of dementia or memory impairment, and they can exacerbate that. So for that, they have very little use. People, theoretically, they would be effective for monotherapy in a younger patient. The idea is that in Parkinson's disease, dopamine depletion produces a state of excessive cholinergic sensitivity, and by giving an anticholinergic medication, you can improve the effects. And clinically, well, pharmacologically, it makes sense, and clinically, it is an effective therapy. However, just the problems that are caused by the side effects just make it so that you wouldn't really try this right away, just because there's better options that don't cause those types of side effects, or less severe versions of them anyway. Amantadine is another product that's antiviral with really unknown, and yes, I said that right, antiviral, unknown Parkinson's disease medication. Probably has something to do with increasing dopamine release or decreasing reuptake, something in there. Maybe monotherapy for early mild cases. And then for people with predominant tremors, if somebody just has really a tremor and no real gait disturbances or anything like that, they might be effective for those types of patients, if that's really the only symptom they're showing. Not really beneficial when added to levodopa, although if somebody is on amantadine and they add levodopa to it, they see a lot of benefit. But that's probably just because levodopa has a much more potent effect. Whereas if you're already on levodopa and you're looking for more benefit, you're kind of at the end of the road to begin with. So hopefully that makes sense. Adverse effects, ankle edema, CNS side effects are infrequent but unpredictable. This is probably one of the better tolerated medications. So if you have a patient who's got an early mild case and really just a tremor, it might be a good option to try, actually. So let's talk about the different possible scenarios here. If you have a 65-year or younger patient with motor symptoms, you're going to start them on a dopamine agonist or levodopa, carbidopa immediately. Which one you pick is a little bit of, I I don't know. It's something that I would have a debate internally with myself with. I think it, like I always ask, what would you prefer once you know a little bit about the drugs? I think I'd probably try my hand at the dopamine agonist, just because the idea of that we know that pretty well that levodopa doesn't really have any neuroprotective benefits, and there's some theory out there that it might actually cause neuronal degeneration. So maybe try the dopamine agonist first in a younger patient if they're having overt motor symptoms. So this is a more severe disease. So somebody with motor symptoms means that they're having gait disturbances and things like that, and they're having issues with their daily living. For somebody 65 years or older with symptoms that affect daily living, you're going to avoid the dopamine agonist for some of the reasons we talked about earlier. And then especially with the memory impairment and things like that, and you're going to go straight to the levodopa carbidopa for an elderly patient with, again, more severe symptoms. If you have early or mild Parkinson's disease, or a younger patient with early mild Parkinson's disease, really any age more or less, with the exception, I wouldn't use anticholinergic in an elderly patient, but monotherapy with an MAOB or Amantadine for a patient, again, with mild symptoms, early disease, tremor. And you could even think, you don't necessarily have to be young. Like, you could have a 70-year-old person who's just starting to develop the disease and showing some early signs of it with just tremor. Certainly one of these would be an effective option for them. So don't be afraid to try those in. Don't get, I guess what I'm saying is, don't get too distracted by this younger patient. Ideally, a younger patient might want one of these medications on board for earlier disease, but certainly could be used for an older patient. Not getting adequate response with these, change your dose frequency. Start Sinemet if you haven't already. Add your MAOB if you haven't already. Try a dopamine agonist. Really mix and match your classes and see if you can come up with a cocktail that is providing the symptomatic relief. One of the things you'll see a lot, like I already talked about, is that dose frequency of Sinemet. So increasing frequency, giving a larger dose at night. So sometimes people will take a really big dose right before bedtime, and then they'll take smaller doses throughout the day to get them through the night. So there's a lot of strategies you can try with the dosing of Sinemet. Long-term complications, daytime sedation and sleep attacks. Sometimes Parkinson's patients, with they're on really high doses of levodopa, they're going to be experiencing this. So sometimes a small dose of an amphetamine type stimulant like an Adderall or a Ritalin can help with that. Hallucination, psychosis, and paranoia, up to 40% with advanced illness will experience this. So again, it's really common. It's basically, once you get to a certain threshold where you've given somebody levodopa over a long period of time at high doses, they're going to get psychotic. It's just part of the way that the body's going to use that dopamine. You can't really avoid it. Again, 40%. So not everyone, I'm exaggerating a little bit, but a lot of people who have this disease in an advanced state will end up with some sort of psychosis type experience. You can't really stop the Parkinson's disease regimen at this point, because then they're going to get worse, or they're going to have symptoms. So hopefully you're getting some control out of the levodopa from the Parkinson's disease. So the question is, what do you do? There are a couple antipsychotics that have been researched, and I don't expect you to know these right now. We'll talk about them next group, so don't worry about them for the exam. But quetiapine or clozapine have actually been shown, which is quetiapine Seroquel and clozapine is Clozaril. They've been shown to be have some improvements in these patient populations. A couple other ones, actually, risperidone and olanzapine, have been shown to worsen it, interestingly enough. Not really sure why. Other conditions that might come up, you just treat like you normally would. There's no real contraindication to treating anything like your hypertension, cholesterol management, all that stuff. We treat as you normally would. So this is really the two large complications you're going to see with long-term levodopa use, and much more so with levodopa use than like a dopamine agonist. Not going to be quite as common to see that with those products. All right, that's that for this lecture. We'll talk about geriatrics next.